People are coming in. Thank you, thank you, thank you. I believe we have our executive director, Marketa, Dr. Marketa Huskova. Marketa, are you here?
Yes, I'm here.
Wonderful. Please take it away.
All right. Good afternoon, everybody. My name is Marketa Huskova. I am the Executive Director of the American Nurses Association, California, ANAC. I'm very pleased to welcome all of you today to this magnificent and much needed webinar. And without much ado, I would like to give the word to Dr. Cecilia Crawford. Cecilia, take it away.
Thank you. So proud to be here. Happy to be here. And let me get this up. Can you see this first?
Yes, we can.
Okay, perfect. So today, Dr. Lorie Judson and I are going to be speaking about a clinical phenomenon that is very near and dear to our hearts, and that is nurse civility and bullying. We're going to be looking at the who, what, when, where, why, how of this, and really explore it in depth. Now, this came out of an integrative review that was conducted a few years ago, and an article that was written. So we're going to look at what is the data, so what does it mean, and now what do we do about it? Lorie, can you introduce yourself?
Sure. Hello, and welcome to our webinar on nurse civility and why it matters. I'm Lorie Judson, former director of the School of Nursing at California State University, Los Angeles, and an emerita professor, having taught for over 40 years. I thought I retired in 2016, but was reincarnated as the executive director of the Chin Family Institute for Nursing. Dr. Patricia Chin and her husband, Dr. William Chin, are the generous benefactors that made this possible. Patricia Chin being an alumna of the now named Patricia A. Chin School of Nursing and later professor and director herself. The Chin Family Institute is committed to addressing healthcare disparities, the healthcare of vulnerable populations, and providing continuing education for nursing graduates at all levels.
And I'm Dr. Cecilia Crawford. I have been a nurse for 40 years, graduated in 1981. I retired in October of 2020 from Southern California Kaiser as the Regional Director of Evidence-Based Practice. I'm also the founder and the inaugural director of the Academy of Evidence-Based Practice, of which Lorie is a member. And this is the group that conducted the review, and we'll talk a little more about them in just a bit. So here are the three objectives that we're going to be looking at today. What this group wanted to do was to really describe the phenomenon for 4 different nurse populations: the nursing student, academic faculty, new grads, and experienced nurses. We're going to be looking at some strategies to mitigate it and give you some hints and tips and coping mechanisms to deal with it. Now, this seminar, although it was developed for specifically for nursing students and new grads, we feel that it cuts across all nursing populations in all settings. Here are the members of the Academy that conducted the review. You can see that we have a lot of service and a lot of academic faculty. But what's unique about our group is we have 3 medical life science librarians. We could not have conducted this review without them because it took them 3 months to pound the databases, to come up with all of the data for us to explore. So hats off to them. And I'd also like to highlight AJ Jadala, Dr. Jadala from Cal State Long Beach. She is a very active member of the Academy, and she's the one that came up with the questions because she saw what was occurring in the clinical experience for her nurses, nursing students. Now, this isn't the first time that this has been disseminated. It's gone to healthcare systems, professional organizations, academic institutions, but this is the first webinar that we have presented. And Lorie and I would really like to thank ANA of California, and specifically Jared and Marquetta, for hosting the webinar and really promoting the clinical nurse and nursing student well-being.
Thank you, Cecilia. And if I might just interject for a moment, there's the presentation bar at the bottom of the presentation. It's just over the screen a bit, if you might be able to move that down. That way everyone can see the content on your slides.
How's that?
That is better. Thank you.
Okay. Before we proceed, yes, thank you. Before we proceed into the bulk of the presentation, I have a story about how one person literally saved my nursing career. She was my life preserver. I was about 6 months out of school, and I was really thinking about going back to the clerk typist position at Napa State Hospital. And that was because I was on the night shift, 11 to 7, and the PM shift was just eating me up alive. I couldn't do anything right, it seemed. Not giving report, not hanging or monitoring my IVs, dressing changes, charting. Charting really bothered them because I did head-to-toe charting as I was taught, but many of them had never done this, and they said, "Why are you doing this? You shouldn't be doing this." So my professional identity as a nurse was really taking a hit here. My resiliency was at an all-time low. And I just wasn't sure that this was the profession for me now. So one night, it was really bad as they were giving me, as we were interacting with them for report. And then my life preserver, Sue, the charge nurse, 5Es, turned around and looked at the group and said, "She's a new grad. I suggest you back off." And that's all it took. One person standing up for me, speaking to not just one person on PM shift, but the whole group. So Sue supported me, she mentored me, she nurtured me, and most importantly, she protected me. I really feel that protection doesn't get enough press, and how important it is for new grads and even new nurses, experienced nurses coming into a facility. Another thing that I did mentally was I created what I called the Resiliency Bank of Crawford. And as I would experience positive achievements and positive events in my nursing career, I would take those and I would make a deposit. And then on the days where I was feeling low and it just wasn't a good day, I'm depressed, I would go and I'd make a withdrawal, maybe 2. So I continue to use that. It really works for me. But this entire experience allowed me to perform, to develop a really positive professional identity, build up my resiliency, and make me confident. So what's causing this bullying, this inappropriate behavior? What's its current state? Who are the instigators triggering this? Who's experiencing it? When is it happening? Where is it happening? This really is the elephant in the room. So we are going to be looking at the what, the so what, and the now what, starting now. Now, before I hand this over to Lorie, I want you to pause and reflect on 3 elephants in the room you think might be related to this phenomenon. Take it away, Lorie. Lorie?
Yes.
Okay.
I thought I had the next couple of, you had the next couple of slides, actually.
Oh, yes, you're correct. So let's look at some closely related and interchangeable terms here. Look at the big one. Nurses eat they're young. This has been going on for decades, decades and decades. And it doesn't seem to be getting any better. I would really like to retire this phrase because it's so negative, and I feel that it perpetuates the cycle. Now, if you look at these terms, you'll see there's a lot of description, passive aggressive, shark, well, there's a term, disrespect, the nonverbal assaults where someone is rolling their eyes and deep sighs and not making eye contact. It's just general harassment and mistreatment. What we did discover, though, was there are many descriptions, as you see here, but no universally accepted definitions. We could not find that in the literature. That was fascinating, but it didn't help us very much. So let's take a look at perpetrators, also called instigators, and targets, sometimes called victims. I try to stay away from that term because it's so passive. It's almost as if they brought it on themselves. So the perpetrators, probably no surprise, nurse peers, staff nurses, leadership positions like supervisors, managers, directors, academic faculty, and because we're a mostly female profession, but that's getting better, females. This also probably isn't going to surprise you for the most part. The students, new grads, the novice nurse, and experienced, those were many of our populations. But the academic faculty cut across, we noticed. And the targets tended to be younger. One thing that did surprise us were males. We have this mental model in our head of a male being strong and forthright and assertive. Well, the literature still is saying, well, they may be all of that, but they're still being bullied. In general, it's the new grads that experiencing bullying, both from their preceptors and their supervisors, their managers and directors. So what are the triggers? Well, there's a lot, and sometimes triggers compound triggers. Now, in this current age of COVID, we certainly have that increased workload, suppressed anger. There's a power imbalance that's going on right now. And this all contributes to that stressful work environment. There's definitely a pecking order. Hierarchies exist within nursing. All of this points to hostility at the end. We discovered that there were overarching themes for nurse incivility and bullying, and I'm going to start at the top. This is one of the ones people talk about the most. There's a rite of passage, it seems, that we all must go through. Older nurses, experienced nurses will say, you know, it's just how it is. You got to pay your dues. And some will even go further and say, I had to pay my dues, and so do you. That just needs to be retired. There's also an element of being out of the clique. You're alienated, you're not part of the group. This particularly happens in specialty areas like the ED and intensive care. It often is part of, there's an education hierarchy. Oh, you're an ADN, I'm a BSN. Oh, you're a BSN, I'm an MSN. You know, we're all nurses. And those of us that choose to further our education, fine, but there should not be this hierarchy. Also, per diem, floats, travel nurses, ethnicity really needs to be brought out, and cultural differences. We're seeing this more and more, and it must be dealt with. Now, in terms of the float, I've got a story. I'm 3 months out of school, still on the night shift. And I go to the nursing office to see where I've been assigned for the night. And I'm assuming it's going to be 5 East. Well, it wasn't. They put me in intensive care. I had 2 weeks of training in my nursing program. I was not qualified to go to this area. And I spoke to the nursing supervisor, and she looked at me and said, honey, you've got RN behind your name just like I do. Go to ICU. So I go to ICU, and as soon as I walk in, the charge nurse turns around, looks at me and says, who are you? I said, I'm from 5 East, but they floated me down here tonight. Oh, no. This is not going to do. So she picks up the phone and has a pretty heated discussion with the nursing supervisor. Did not end well. She slammed the phone down and looked at me and said, okay, you're stuck with me and I'm stuck with you. Stay out of my way. Oh, only 3 months out of school. I did fine on the shift. I feel that my patients received quality and safe care, but I cried all the way home. Well, apparently, if you survive an experience like this, they tend to float you back. So I was floated to intensive care thereafter. If you look down to your left, you'll see that there's a term that we were not familiar with, and that's structural bullying. And this is by your boss, by managers, directors. It's usually punitive actions that take place of you called in sick again. You want vacation? No. You can have vacation over here, but not there. And then you get those really ridiculous patient assignments, heavy workloads, and we certainly are seeing that now. Unreasonable deadlines. My daughter will never forgive me for missing her first day of school because they wouldn't give me the day off. And my boss said, look and see if someone will switch with you. They wouldn't. And she reminded me, you call in sick, I know where you are. So I'm sorry, daughter. Down at the bottom, you'll see nurses eat their young. There's that theme again. There's a perception that this starts as soon as you're employed, but it really starts in nursing school. Academic faculty and the nursing students themselves will tell you this. You roll all of this up, and you've got people that are leaving their unit, leaving their department, leaving their hospital, leaving that job to go to another hospital, or just leaving the profession altogether. And that certainly is being highlighted now during the current time that we're in. Now we're going to talk about the so what of the data. And Lorie.
Thank you, Cecelia. Yes, so what? What are the outcomes and consequences? Is it a rite of passage? And are there consequences? That's what we're going to talk about next. In our integrative review, we found 84 separate and different negative outcomes as a result of incivility and bullying. Approximately half of them focused on the organization and work unit outcomes, and another half were related to personal outcomes for the nurses who were the targets. The next 3 slides depict those outcomes. Although these outcomes are categorized into organization and work outcomes, as well as personal consequences, we're also well aware that the patient can become a target or a victim as well. If communication is withheld or falsified, work is blocked with decreased productivity, and communication is threatened, this becomes a patient safety issue. So in this slide, we see that the outcomes are categorized. They fall into these groups: fractured care delivery, damaged relationships, reduced organizational commitment, which creates a toxic work environment, lack of critical information sharing, a safety issue, and little sense of community. And the final outcome is what we call the erosion of professionalism. Although professionalism and professional identity in nursing has always been part of nursing practice, it's been highlighted recently by the adoption of this concept into the core competencies of professional nursing education by the American Association of Colleges of Nursing, or AACN. Domain 9 in those core competencies outlines the formation and cultivation of a sustainable professional nursing identity, accountability, perspective, collaborative disposition, and comportment that reflects nursing characteristics and value. The International Society for Professional Identity in Nursing, or ISPN, and their work led by Dr. Nelda Godfrey from the University of Kansas has informed this inclusion. This domain competency emphasizes demonstrating ethical behavior, a culture of civility, and emotional intelligence, which I'll discuss in a bit. In this slide, we see individual outcomes of incivility that can broadly be placed into two outcomes that threaten the satisfaction and the personal, emotional, psychological, and spiritual health of the nurse affected. We can go to the next slide. So the satisfaction and overall health is affected with this outcome.
Thank you, Lorie. Now we're going to look at something that we did not anticipate coming up in the literature, and that is the flip side of the coin, the nurse manager perspectives. The literature went quite in depth for this, and if you see at the top, this is a big one. Probably many of us have experienced where you've got someone on the floor, been there for 25 years. They know absolutely everybody in the hospital. They've got a lot of informal power, and they're clinically experienced. They might also be narcissistic, loud, abrupt, just in general inappropriate, snappy. If someone goes to their manager speaking about this, often the phrase that you'll hear is, well, that's just how he or she is. Well, it's just how they are. And we can't afford for this nurse with this experience to go away. The unit just will cease to function. So that kind of spills over into old baggage. Say you've got a novice nurse that comes onto a unit, and that unit's had a lot of turnover of managers, maybe 2 or 3 over 5 years. One of the reasons that there's been turnover is they have been unable to resolve ongoing conflicts, such as that clinical nurse who is a bully. Well, if they can't do it, how is this novice nurse going to handle it? This is a real issue, and it happens all the time. There's a lot of things going on, particularly now. We've got a very stressful environment. To say that we have high census is a gross understatement. Critical events will happen on the unit, and if you fold in just the basic personality of a nurse that's really negative, the bully with inappropriate behaviors, there's going to be an explosion sooner or later. On the other side, you'll see the victims can be passive and they just take it. I know some people wonder, well, why? Well, they're probably, from the literature, they're trying to keep a low profile. It's if they're quiet and they just go about their business, maybe nobody will notice them and they won't be bullied. So they tend to tolerate this behavior, but they don't react. They're very passive. If this person that has been experiencing a lot of this goes to their nurse manager and says, I have to talk to you, I got to get this off my chest. And they tell them about the bully, the hostile nurse, and they just unload. But then at the end of it, they'll say, oh, please, 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 you can't tell anybody. And particularly, you can't tell so-and-so because she'll come back at me and it's just going to be worse. Well, what they don't realize is the manager now has an ethical dilemma. It's called a moment of discovery. He or she has a obligation, a corporate obligation, compliance obligation, and quite frankly, a moral and ethical obligation to follow this up. It can't be tolerated in our profession. And that's when you'll discover there's probably three sides to the story. There's the victim's side, there's the instigator's side, and very often the truth is somewhere in between. So before we move on, let's take like a 30,000 view look at what we've talked about so far. We've got our closely related terms and definitions that we can make using those terms. But we've got the triggers, the instigators, and the targets. And once we understand those, then an assessment can be done of either the unit or the department or the organization. And this is to explore the who, what, when, where, and how, and maybe why. But the why requires really digging deeper to see what's going on. Then you're able to identify what's really happening in a particular area or maybe in the entire hospital. These are different categories. Lorie will speak to them later, but is it direct? Is it overt? Is it indirect? Is it covert? You know, the eye rolling and the sighing. Is it structural bullying that we previously discussed? Is it just the personality of the nurse? This is where decisions must be made. Are you going to passively accept that this is just the way it is? Or are you going to proactively determine what types of strategies and facilitators and behaviors that you need, that the organization needs to establish a just and safe culture that does not tolerate bullying? It's going to impact patient care. Now, the passive choice is going to lead you into a hostile work environment. That's conducive to this type of behavior. It's almost like a malignancy that grows. The proactive choice, this has real potential to create a nurturing, mentoring, protecting place for people that can be kind and civil and, quite frankly, be humane. So deep thought needs to go into this type of assessment and moving forward. Lorie?
Right. I've been kind of looking at the chat here, and I can see that this question has, or this topic has raised a lot of experiences that people are kind of discussing in the chat. So this is kind of a rhetorical question here. Have you experienced any of the outcomes for incivility? So I think that there are some people who are listening who have, and I'm sure know of instances where there have been negative outcomes. The most negative outcome, of course, is that nurses leave the profession. And what we've seen is that can amount to 20% in the first year after nursing school. And we can't afford to lose those nurses, particularly now. So this is the next question. Now what? Now that we know the consequences, what can be done about it? Cecelia outlined some of that just in that previous slide. But let's take a look at some prevention and management strategies from the perspective of the administration and the victim. First, we need to look at what we can assume is a definition of incivility and bullying. Incivility sometimes is related to what we call lack of respect. It can be psychological in nature. The perpetrator is inconsiderate, rude. It may be low intensity, and there might not be a real intent to harm the target. Whereas bullying is a little more severe. It's repeated, insulting, offensive, abusive, or intimidating behaviors, abusing power, unfair sanctions, making people feel humiliated, vulnerable, and threatened. And of course, it creates stress and undermines self-confidence in the nurse. Mobbing is something that we found in the literature, and this is bullying behavior carried out by a group. And as Cecelia alluded to earlier, that can sometimes happen in a intensive area like intensive care or the emergency department. And when I when I speak to students or new grads, I sometimes talk about the threat that a new grad can pose to the staff nurse. And the staff nurse may think to themselves or actually wonder about this new grad. Do they know more? Will they ask questions I can't answer? Will they outperform me? Or the mindset that we alluded to earlier, and that's, it was tough for me as a new grad, I'm going to make it tough for them. So what we can do is this slide, and if we're the ones in charge and setting an example for the staff, we need to strive to understand the triggers for bullying and incivility that Cecilia talked about early. It could be the organizational culture, it could be the work environment, or the stress of the work itself, or it could be related to the makeup of individual nurses and or their emotional intelligence. We need to go back to that other slide. I wasn't quite finished yet, okay? We need to recognize the categories of incivility and bullying, which Cecilia also mentioned earlier, including personal affronts, indirect and covert, which might mean withholding information. The person's not approachable, they're cold, they sabotage the target. Where we have reactive and proactive, might be the target feels offended. Direct and overt, these are verbal remarks that they're heard, and threatening body language. And then we already talked about the structural and work-related that might affect scheduling, sick vacation time, and unmanageable workloads. We have to ensure that all nurses are familiar with incivility policies in the institution. And then they also have to be applied universally by all the managers and the senior leadership. And lastly, we need to provide resources and support to new grads. And that means not only a preceptor, but a mentor as well. Now we can go to the next slide. So leadership can and should have a positive impact. Good leaders practice authentic leadership and provide a professional nursing practice environment. They give power to their staff and have zero tolerance for incivility. They reward creativity and have a primary role in addressing incivility. In other words, they need to lean in and lean forward. Now, what can you do as the staff nurse or the new grad? The first thing is that you can investigate programs, tools, and resources so you can deliver quality care and be successful. In the interview process, you can ask about the organizational policies and incivility in that institution and observe the interview panel. Be familiar with the American Nurses Association Code of Ethics. This was adopted by the ANA in 1950, but reaches back to the early 1800s and was revised in 2015. Specifically, the first provision, which states the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. And it's further clarified by saying that the nurse creates an ethical environment, a culture of civility and kindness. And it goes on to decry bullying, harassment, manipulation, threats, or violence as morally unacceptable behaviors. Finally, you need to practice self-awareness. Are you the bully? In a short article that appeared in the publication American Nurse Today, the author, Dr. Renee Thompson, presents a short questionnaire to develop that awareness and tells the story. A man was curious about who was the, quote, mean guy in his neighborhood. He states, people were always talking about this mean guy who lived on our block. I decided to go see for myself. I went to his door, but he said he wasn't the mean guy. The mean guy lived in that house over there. I said, no, you stupid idiot, that's my house. So this was the bully himself. And we can go to the next slide. What all of us can do. Cecilia touched on this earlier. We can create structures that create infrastructures. You have to have an infrastructure there. You have to have policies and practices to foster work civility. Then there has to be a process for maintaining civility through the organization, and individual efforts need to be in place so that the outcome is improved nursing work environment and patient outcomes. This is a nice little pyramid that provides a leveled intervention guide for inappropriate behaviors. As you see on the bottom larger part of the pyramid, the widest portion is telling us that for the vast majority of professionals, there are no issues. But these nurses do need to have feedback and recognition to continue their good work. However, the next level up indicates that perhaps there was one concern that might have happened to a nurse, and it's not egregious. So what we advise and what this pyramid advises is that the person sit down with that perpetrator and talk about it over an informal cup of coffee and have a chat about it. However, if it was an egregious affront, then the mandated review needs to be done, and that needs to go directly up to the top for disciplinary intervention. Level 1 then presents an apparent pattern of uncivil behavior or bullying. To the new grad or anyone who's being affected by this needs to be documented. You need to jot down the time, the date, and the details to establish the pattern. Again, the perpetrator can be approached with this information either by the victim or the manager, and warnings given. If it reaches the next level, level 2, where the pattern persisted, here you need to have guided intervention by authority figures on the unit. And then at the final top, if there's no change, the perpetrator will need to be disciplined or removed from the situation. Unfortunately, incivility or bullying can lead to fear in the victim. Fear does not lend itself to the best performance or ideal patient care. Florence Nightingale realized this when she expressed this thought: how very little can be done under the spirit of fear. What would you do if you were not afraid and were brave enough to try something new, as voiced in the next slide by the iconic Dolly Parton? And this slide talks about psychological capital, or PsyCap as it's sometimes called. And it says to you that interpersonal skills are usually developed early in your life, and they may be difficult to change. However, you can build psychological capital, as Cecilia talked about earlier. And it's a composite of 4 psychological resources: efficacy, optimism, hope, and resilience. And it can be built and strengthened. 2 other factors come into play here as well, and I spoke about that earlier, and that was emotional intelligence, which promotes skills for self-control, flexibility, and resolution, and encourages a person to stop and think and choose an appropriate intervention rather than jumping to conclusions and possibly hurtful interactions. The last factor here might be appreciative inquiry, which assumes good intent and thinks about what this person is going through. It doesn't jump to the dark side. We did find in our review that the perceptions of bullying gradually abated with time and as nurses aged. Did they develop a thicker skin? Or as they aged, were they more respected for their knowledge and expertise? Now we can go. Despite incivility, nursing remains the most respected profession and has for the last 19 years. And now this slide asks, what one thing could you do today to help reduce incivility and bullying in the workplace? So that we ask our students and you as our audience today to think about that. To maintain the level of respect, we need to act as moral agents and develop quality relationships, not focusing on flaws we discover. In other words, we all need to get along, as these two guys are showing in their Get Along shirt.
So thank you, Lorie. Now it's time to chat just a little bit after we look at a couple of documents. Let me go and get them. And can you see this? Yes.
Mm-hmm.
Oh, this is for later. Here's the one. Can you see this?
Not yet.
Not yet.
While Cecilia is getting that pulled up, it's just a great time to remind everyone that this webinar is being recorded, and the documents and recording will be shared after the webinar. Thank you.
Now, we promised that we would be exploring some coping mechanisms in detail and some strategies for you to employ. One strategy to start with is, before you're even employed, determine what is going to happen during your interview. One thing that new grads need to be aware of is, now you're a registered nurse. You're not a student anymore. And that's kind of a mental switch that needs to be flipped. And I'd been a nurse, RN on the floor for about 6 months, where a supervisor very kindly took me aside and said, "Cecilia, you're going to be a great nurse, but right now you're still acting like a nursing student. And we need for you to be an RN." So that was a huge heads up. So as you go into the workplace to interview, try to determine, do they have a civil environment? Do they have a place where appropriate behaviors are documented? You know, so you can understand what they're looking for. Zero tolerance for these type of behaviors. One technique is to just ask, do you have a civil environment? And I think you would be very surprised at the responses. I've asked that question a couple of times in some interviews. And one time, the lead panel interviewer just stopped cold. Nobody was saying anything. And she said, "Well, everything you've ever heard about incivility, it's true. So if you get that kind of response, maybe this isn't the place that you want to work. You need to determine if there's some type of support system to deal with inappropriate behaviors. And this includes, you know, your managers, your boss, nursing leadership, your peers, mentors. Preceptors have a different function. If they wish to become your mentor, they can. Watch the interview panel as they're interviewing you. Again, it's the overt and the covert behaviors, you know, the smirking, the eye rolling, lack of eye contact, the rocking back and forth in the chair, not paying attention. Does the atmosphere seem really tense and uncomfortable? Does it look like the individual people don't get along? And if they don't get along, then again, maybe this isn't the place to work. Solicit information about both their new grad program, if you're a new grad, and their new employee orientation for new grads and for new nurses coming in. You know, what are the components of this? What types of supports do you have? Do they have mentoring opportunities, a real formal program that you can participate in? Do they have regular peer group meetings where you exchange ideas and try to problem solve? Now, one thing that did come out of the review is the greatest need for support for new graduates is 1 to 3 months. It's got to be there or you're going to lose them, and they're going to lose themselves. As Lorie said, this is all about relationships. Our entire life is about relationships. So we need to make sure they're respectful and healthy. Finding the mentor we've mentioned, but bonding is so important with everyone that you come in contact with on a regular basis, your peers, your colleagues, the nursing supervisor, your manager, EVS. I've had wonderful relationships with EVS. Get to know these people, but it's not going to happen in a month. It's not going to happen in 3 months. It could take up to a year. So expand your support system at work, and also try to strengthen your support system while you're away from work. Feedback is really important, and if you ask for it, you've got to be willing to receive both positive and negative. Some of my most treasured learnings in my life have come from pretty negative experiences that I wish I could go back and redo again. But what you need to do when you have these is, after the talk, sit down and say, okay, what did I do right? What went well? What would I do over again? We've mentioned the policies several times. We've talked about the new grad program, but if they've got a residency program, investigate that. That can be incredibly valuable and really strengthen your professional identity, your resiliency, your confidence as a professional nurse. Role clarification. I sure wish somebody had talked to me about this when I was a new grad, and quite frankly, in other roles. What do you expect of me? And then you need to ask yourself, what do I expect of them? What do I expect of myself as a new grad, as a new nurse? Have that discussion so everyone's on the same page and you're not making assumptions. Those assumptions can really lead to conflict. Lorie's talked about the code of ethics. I know this is recently updated. This is key. This is your Bible. This is how you operate as a professional nurse, with morals and being authentic. ANA wrote a white paper of violence, incivility, and bullying in the workplace. I was proud to be a panel member with, gosh, over 100 other nurses across the nation. And we compiled a lot of resources, a lot of information that we passed off to the steering committee, and then they wrote this report. It was really enlightening experience. As Lorie has mentioned, psych cap, emotional intelligence, interpersonal skills are crucial, not just as a nurse, but as a human being. It allows you to become empowered, so that if you see something happening that isn't right, or even if you suspect it isn't right, it gives you the confidence to speak up. So you can develop that self-awareness, that self-reflection, to look back and say, this is what I did well, and this is what I could do better. I also wish somebody had clued me in about conflict negotiation skills. There's a nice little reference. It's a text called Crucial Conversations, and it was incredibly enlightening. It helped me fine-tune how to deal with difficult people, how to deal with a difficult situation. I really enjoyed it, and I still go back to it. And there's that psych cap again. And there's the resiliency bank, accumulating those positive work experiences so that you are hopeful and positive and optimistic, and you bounce back like a rubber ball. Being an active member in the work environment, being seen as a contributing, engaging participant in the work, in patient care, on committees, making yourself visible. This is really going to help your not just professional development, but also your personal development. And as we've said before, refuse to accept anything less than zero tolerance for inappropriate behaviors. No, it's not okay. If she's the clinical expert and a bully at the same time, something must be done. So here we go. This has nothing to do, this next document, with incivility, but since we talk so much about the night shift nurse, hints and tips for surviving the night shift. Again, I wish someone had clued me in. I had to learn all of this the hard way. I loved the 11 to 7 and then 7P to 7A shift. It allowed me, in my opinion, to get a little closer to the patient. However, you're really at risk for a lot of negative factors such as disruption in your circadian rhythm and sleep. Sleep has got to be a top priority, absolutely. Don't go shopping, don't go visit your mom, don't make doctor's appointments, leave those for your day off. You need to go to bed so that you are healthy and strong. And you can see here are some hints to manage it. Now, there are just some people that they're larks, they're day shift people, and this shift is not going to work, and they usually find a way to move on to another shift. But I loved it because I'm a night owl. Circadian rhythms. Learn your circadian rhythms. Sleep, you get a little sleepy after midnight. I worked mostly burns, critical burns in my nursing career at the bedside. And we had something that we call the 4 o'clock sillies, where sometimes if we just worked so hard, hadn't had a break, hadn't had much to eat, it would just sock us right in the face and we were giddy. So you need to learn what triggers it, learn your natural rhythms, and adjust your clock. Don't drink a 6-pack of Diet Coke. Don't go to the vending machine and count that as a meal. Bring your own food. Night shift orders out a lot, or at least used to. And stay away from an occasional pizza's fine, but not every day. And a Tommy's burger or a chili dog is just not going to help you. And that leads into staying active and exercising, which can also help your physical health and monitoring your mood. Look and see if anything's triggering mood swings. Being out in the sunshine will really help. We're human beings and we need that sunshine. And again, we keep talking about this, be visible and bond. Extroverts sometimes do better on day shift because they're such social creatures, and that's where the action is often. But on the night shift, introverts, believe it or not, I am an introvert. Introverts can do very well on the night shift. So this is just some tips for new grads and probably experienced nurses now. And I'm going to hand it back to Jared.
Wonderful. Thank you so much, Cecilia and Lorie, for this presentation. We had the chat seemed like it was going a million miles an hour over here. So many people have their own stories and multiple times throughout their careers. So very sad, but also glad to see people sharing their stories. We do have quite a few questions that have popped up in the chat. I'll go ahead and kick off a couple of these now. While I list some of these off, for our presenters. If you have any other questions, please feel free to continue to use the chat and ask them now. Looks like one of the first questions that we have here is, could you expand on the different categories of bullying and incivility and just share some examples?
Sure, I can do that. Yes, in our integrative review, we ended up, I think, using some 21 references. Is that correct, Cecilia?
Yes.
Right. And it was interesting to look at the bullying categories. And the ones that we came up with were the personal, as I mentioned before, indirect or covert, direct or overt, and structurally work-related. The personal ones many times came from peer groups or cliques. They felt that they were justified sometimes because if they thought that the peer performance was seen as inadequate. They also were, of course, fostered by the organizational culture because they weren't reprimanded. And many of them can be informal, exclusion, joking, practical jokes, excessive monitoring of someone's work, always checking up on them, humiliating someone, embarrassing them, disrespecting them, degrading them. And those are some of the examples. And unfortunately, we've all probably seen those happen. The indirect or covert were, the target might not even be there, but they're still being abused or treated civilly. It may be a nonverbal innuendo type of thing. It might be unspoken. There's an actual pecking order, as we talk about with chickens, but that can happen on a unit as well. Some of the bullies have unapproachable behaviors. In other words, this is one of the ones that I talk to students about. They act like that because they don't want you to ask them any questions because they're afraid they won't know the answers. So they're just cold and dismissive. Their demeanor is not friendly at all. They may actually inflict emotional abuse. They withhold information that the nurse needs. They don't recognize when you speak to them. They ignore your comments, your opinions, and they may even sabotage you or put you down. Then the direct and overt are very visible for the most part. There's verbal affront and remarks, condescending, patronizing language, broken confidences. They promise something and it doesn't happen. Scapegoating, you're to blame, I'm not. Backstabbing, gossip, infighting, lack of respect for privacy, threatening body language, and even threatening verbal language, yelling, angry, outbursts, throwing. Sometimes we actually see some physical violence and actual physical abuse. And then the structural work related, we talked about pretty much in depth already. So
it just seems like such a long list, and I think it's so helpful for viewers here to see that list of words and realize, yeah, I've experienced those. You know, a lot of questions here, and I think is because maybe there was a slight angle focused on, you know, your job and getting your first job, new grads, new nurses, etc. But there's so many stories here in the chat have been shared about their experiences in the academic world as a student or even as faculty. So what would you say are you know, tips or tricks or things that these nurses can take into the academic world, and how can we essentially improve the culture of civility in academic institutions?
actually, I gave a lecture, or not a lecture, a talk to faculty at Cal State LA at one point because we thought that we were seeing something along those lines among faculty themselves. And basically we talked about some of the same things we've talked about in this presentation, that what constitutes, sometimes people don't realize that they're being the bully, and what constitutes incivility and bullying. And then, that the fact that it can't be tolerated. But some of the same issues arise there. I know when I speak to student groups, which I have over the past year fairly frequently, many of them will talk about what they perceive as abuse, and probably is abuse from faculty. And I remember myself back in my diploma program that it was considered at that point to be a rite of passage. In other words, if you can make it through these 3 months, then you'll get your cap. But if you can't, you won't. And so we, at the time, we accepted that as being the norm. But as I mentioned in my piece of the presentation, you can't do much if you're afraid. And if you're a student nurse who's continually being put down by your instructor, I don't care how smart you are, that person can reduce you to tears, and you won't be able to respond at all. So I think that, again, it's the culture that's fostering that in the School of Nursing, wherever that is. And I think that it needs to be documented by students, and then needs to be addressed by the administrative people in that situation, either on the unit or in the school, because it has to come from, there has to be that culture in place for it to be not only recognized, but to be dealt with.
Lorie, you triggered a memory here of when I was in nursing school. I still can't believe this happened. There was a pod of about 4 student peers that simply just did not like me. And that's okay, people don't like other people and you can still get along, but they decided to be vindictive. And during lunch, they were discussing how they could set me up for a medication error at our pediatric rotation. Another student who was a colleague of mine, a friend of mine, they didn't know that she was behind a screen in the room. And she heard the whole exchange and she came to me and she says, "I will deny this. You never heard this from me, but this is what's going to happen." So I was appalled. And I immediately went to my instructor. She thought I was nuts. She thought I was having delusions of paranoia, and she wouldn't do anything about it. So I went to my little pot of people, of friends, and we came up with a plan that during rotations that they themselves would watch my pediatric patients when I went on break and for lunch, and they would not let any of these other nurses come near, because it's not just the medication, it's going to harm the patient. So that is an extreme example of peer-to-peer in hostile, inappropriate behaviors within a school of nursing. I've never heard of anything since like that.
Cecilia, thank you for sharing that and your many stories today, and Lorie as well. This is a perfect segue into a question here. I saw Carolyn, I think maybe even one other may have asked it, which is relating to a zero tolerance policy. Did you encounter that? Have you encountered that? What do you have to say in terms of a response to that type of policy as we look to try and address multiple forms of incivility in the workplace?
When I was at the bedside, I left the bedside in 2000. And in any place I ever worked, there was not a policy specifically addressing bullying. It was vague terms of inappropriate behaviors, go to your supervisor, work up the chain. And I know people that tried to do that and they were blocked. And a lot of times, unfortunately, it was no, this person is the clinical expert. You'd be surprised how often that happens. No, this person is a clinical expert. Do you know how hard it is to hire a nurse? Geez, Cecilia, if and Stacy and other people, if you want to get rid of all these people, we wouldn't have anybody staffing the units. Lorie, anything for you?
Well, only that I can say that when I was at Children's Hospital, which was many years ago here in Los Angeles with my students, I didn't see it except for one time when I observed a nurse essentially bullying one of the children. And I reported it immediately and it was taken care of immediately. So I think it does make a difference in where you are and who you're working with and what the policies are. I think that as a new staff nurse or a new grad, this is why we ask you to ask about those policies before you come into the institution, because you need to know that there is a policy there. I also recall a student that I had who was working as a student, had her clinical rotation in a ICU, a specialized ICU. But when she came in as a new grad, she was harassed and bullied and she left because she changed her role. Now was no longer a student. Now she was one of them. And it's in those ICU situations, there's a group of nurses who know what they're doing, obviously, and they resent when someone new comes in and can be destroy that person. So the culture is important, and it again needs to be documented, and hopefully hospitals or facilities are doing exit interviews so they'll know that this is happening and address it. In this time right now, when it's threatened that we can lose 20% of our nurses because of the pandemic and working situations and so on, I think it becomes even more imperative.
Thank you so much, Lorie, for sharing that. I promise we're not somehow setting this up with the questions, but you just mentioned a story in which you were a bystander. And one of the questions we had in the chat here was, what is the role of the bystander? So what would you suggest? What could be some tips for them to approach that situation and hopefully have it resolved in the best way that it should?
I think from my perspective as a bystander, and I guess this probably comes from being in a role of a director and so on, is that each of those people need to be talked to individually. First of all, what happened, and Cecilia mentioned this earlier. You need to get both sides of the story and find out what was really going on and what are the issues here, and then work from that. Too often people just look at one side of the story and don't ask both participants in it what triggered it, what was going on, what happened beforehand that might have led to this. So just from my perspective as being a director, you need to look at both sides of the story and then make up your mind. It's easy to jump to conclusions when you just hear one side, and particularly if the person is very verbal about it. But in this instance of being a bystander, that's exactly what happened when I was talking about the incident at Children's Hospital. I was a bystander. I heard this happen in actually the bathroom. So I immediately went to someone and they did something about it, right away. Yeah. So I think as a bystander, that's your role, is to tell someone about it, and then for that person, whoever's in charge, to start the investigation.
Yeah, the nurse manager or director really has a responsibility here. It can't stop there because it's just going to continue. Everyone needs to be brave here, and it's hard to be brave.
Maybe just leading off of that, you say you go to your immediate manager and it's sort of a brick wall, or maybe that situation is incivil in itself. Then what do you suggest?
You jump the chain of command.
Yeah.
I mean, you just have to. You work your way up.
Yeah.
In clinical situations, I've had to do that where, I couldn't get a doctor to respond and I just went directly to the chief medical officer. That's a little radical, but you work your way up the chain of command. They're in leadership positions for a reason: to lead, to provide questions and resources and support the frontline staff.
Thank you. Thank you for that. I think I've got one final question for you all, and I think this one might be the most, well, I shouldn't say most important, but and so many people joining us today, for so many stories, I'm sure there's people that are experiencing these situations right now. I mean, they may have just left work and experienced something. So what would be your one go-to tip or action for them when they go back to work tomorrow to change the situation that they've been experiencing? Cecilia, maybe start with you, and then Lorie, if you don't mind answering as well.
You really need to talk to the person, and I have had to do this, and it can be excruciating because they're going to rationalize. They might yell. They may deny it, like, no, wait a minute, everybody in the nurses station saw this. What do you mean it didn't happen? And if they won't crack, then you're going to have to move further. But if you can have a constructive conversation, because maybe your behaviors aren't appropriate also. So there needs to be a meeting of the mind of how can we solve this? How can we get along? And sometimes you can't. And then people do end up moving if it can't be resolved. But I'd like to think that those are rare. In most instances where I've had this type of conversation, I've come away with a better relationship.
Yeah, I agree. I also advise students or new grads to do the same thing, and it is very difficult sometimes for them to sit down with a person and speak. But I think sometimes the bully doesn't realize how he or she is making that person feel, and if you never say anything about it and kind of just meekly go on your way, but are quaking every time you come to work, that's obviously not a good situation to be in. And so do you stop and say, wait a minute, that wasn't, I didn't think that was appropriate, that bothers me, and this is why. Difficult conversation for sure, but may be all the difference there in the fact that this person didn't realize that was inappropriate behavior, or that they've been bullied so often themselves that they think that's the way it should be. And that's the only way that someone's going to learn to be better or different or whatever the case might be.
That's a really good point, Lorie, that negative role modeling. Role modeling is role modeling, whether it's positive or negative. And if the negative role modeling comes into play, then inexperienced nurses will say, well, this is how you're supposed to act.
Mm-hmm.
So we're going to throw in one more question if you two are all right with it.
Yes.
I just got a message on the side, and I really appreciate this person reaching out to ask this question. It's very important. It says, what do you do about a narcissistic individual whose bullying is covert and that person is in leadership? That's a tough one.
That is a tough one. And I have encountered that. Positions of power can be just intimidating is quite an understatement. going, if you have the talk and nothing happens, going to their director if nothing happens, going to their director if nothing happens. And by the way, there's always the compliance hotline or whatever you have at your institution where you don't have to identify yourself. And I actually have known people that have done this where they've called the compliance hotline and have stated what was going on and then said, you know, this is a toxic work environment. I'm not so sure how long I can last here if things don't change. And then they will usually investigate.
Yeah, I agree. That would be, I mean, I was once in the Army, and in the Army, you do have an actual chain of command, and it is very, very difficult in that kind of a situation to go beyond, because you know, it's supposed to be a movement up, and also, of course, because of you know, the rank order there. There can be a lot of, you know, incivility and bullying going on. But again, it can get past that person and go to the next level if you're willing to pursue it.
And if nothing happens, if you keep going up and up and up and nothing happens, then maybe this is not a place where you wish to be.
Right, you need to leave.
I think we can end it right on that note. Thank you, Dr. Crawford and Dr. Judson, so much for this topic. Thank you, everyone, for coming. Please thank the presenters for the time today, and we thank you for your time today for joining us 1 o'clock hour. As I mentioned before, the recordings, this event was recorded, and members should be getting their CEU evaluation form. I believe it is scheduled for about 3 p.m. today, so just wait a few minutes and you should have it in your inbox. If you do not get it, I'm putting my email in the chat right now. Please reach out and I'd be happy to get it to you. Thank you so much. Take care, everyone.
Thank you, everyone.